So my name is Amanda Warren, and I'm the pharmacy supervisor for our hospital in Nebraska City, Nebraska. And I have worked in hospital pharmacy for 12 years, and 10 of them have been with CHI Health, which is Catholic Health Initiatives. And I just wanted to know, a quick a show of hands, how many of you guys work for a hospital or a hospital setting? Great. Okay, it's good to know to judge how many people work in that setting. So when you think of the word hospital, though, that's a pretty broad term. Not everyone understands that or knows about it, but I think of hospital as, when I try to talk about this, as like ordering a pizza. You might be thinking, well, why pizza? Well, if you went up to a waiter and said, "Hi, I'd like to order a pizza," okay, that's great, but what kind of pizza? Okay? Do you want all the toppings, everything? Or do you want a specific specialty pizza, like my daughter, who only wants like cheese pizza, nothing else? You know, pizza could be the entire pie. It could be the jumbo size, where you get everything, or a specific slice of pizza that's just individually just for you. And so my specialty is that slice of pizza called a critical access hospital. Okay? So we're going to go through the learning objectives. We are going to define the characteristics of a critical access hospital. Another term for it is CAH, or C-A-H. So if I say CAH, that means critical access hospital. We are going to talk about the main services provided by a CAH pharmacy, in particular, pharmacy technicians. And the third objective is to summarize the advantages and disadvantages for working for a CAH hospital or CAH pharmacy. First, I'd like to have some pre-presentation questions, if you can jot something down. And there are 4 of them. I'll give you a couple of moments here to answer the questions. I'll go ahead and read them. Which of the following is an advantage of working for a critical access hospital? A, after-hours coverage. B, a level of care limitations. C, drug access. Or D, a broad range of skills. Okay? Next question, and we can go back later if you need to. What qualifications are required to be considered a critical access hospital? The hospital must participate in a state Medicaid rural hospital flexibility program. B, the hospital must have 25 or fewer acute care inpatient beds. Or C, the hospital must provide 24-hour emergency care services 7 days a week. Or D, all the above. Okay. 4th question. Which of the following is not one of the 5 rights of drug administration? A, the right patient. B, the right time or frequency. C, the right doctor. Or D, the right route. Okay. And the last question. Which statement is true about the 340B drug pricing program? The program allows a qualifying entity to purchase outpatient drugs from manufacturers at discounted prices. The program is not subjected to federal audits for program compliance. The program is a local drug price control program, or the program serves all patients in rural communities. Okay. All right. So the theme for the presentation is meant to shine. So I picked out 4 pharmacy technician code of ethic principles to focus on. I'll go through these quickly. The first one is the pharmacy technician's first consideration is to ensure the health and safety of the patient and to use knowledge and their skills to the best of his or her ability in serving others. The pharmacy technician supports and promotes honesty, integrity of the profession, which includes a duty to observe the law, maintain the highest moral and ethical conduct at all times, and uphold the ethical principles of the profession. The pharmacy technician assists and supports the pharmacist in a safe, efficacious, and cost-effective distribution of health services and healthcare resources. And the last one is the pharmacy technician maintains competency in his or her practice and continually enhances his or her professional knowledge and expertise. The last ones, 3 and 4, I'd like you to focus on because, to be honest, our pharmacy technicians are my right hand when it comes to what they do for our hospital. Okay. So we're going to talk about the types of hospitals in the United States. Think again about that piece of pizza, okay? You decide I want a piece of pizza, but then you got to figure out how are you going to slice that pizza, okay? So we're going to slice our hospitals into different sections and different segments, okay? And a hospital can be divided by the size, by the location, by the demographics, finances, and affiliations. Okay. The first way that we can divide a hospital is acute versus long-term. And you can see the percentages right here. I forgot to mention that the total number of hospitals in the United States in 2019 was 6,090. That's how many hospitals we have. So, an acute hospital focuses solely on the treatment and care of people for short-term needs, such as illnesses or diseases, injuries, maybe surgeries, OB or obstetric care, postnatal care. They are not equipped to handle chronic or long-term care patients. And as you can tell, most hospitals are 92% are acute hospitals. And when we define acute care, they usually stay in the hospital for 10 days or fewer. The next one, for-profit versus not-for-profit. And you can see it's kind of the same, a little bit more non-profit, not-for-profit. The definition of that. For-profit hospitals are investor-owned facilities, which means the profits that they earn goes to shareholders who have invested in the facility rather than back to the hospital for improvements, new services, or medical advancements. Okay, and then for not-for-profit hospitals, nearly 2/3 of all hospitals located in urban areas are considered to be not-for-profit, meaning that they do not have shareholders who earn profits from the hospital. Many of these nonprofit facilities receive tax benefits that are unavailable for for-profit hospitals. Third one, community versus non-community hospitals. So a community hospital is defined as a hospital receiving local community services without federal funding. They can be found in rural or urban settings and provide services to their local populations. And a non-community hospital is another term that is used to reference federal-funded or government hospitals. While community hospitals exist to serve the short-term acute care needs of the general public, non-community hospitals are often provide a specific group of care for a patient, such as veterans or Native Americans. Okay? There are urban versus rural hospitals. Nearly 62% of all community hospitals are urban hospitals. Urban hospitals provide services in areas with dense population, and they range from about 100 to 500 beds. Many urban hospitals face dense competition and intense competition with multiple hospitals and medical centers serving the same geographic area. And a rural hospital is usually fitted with 100 beds or fewer. Rural hospitals are located outside the large urban areas and operate on small budgets. I can attest to that one. They generally provide basic care. If they need more care, they'll transport a patient to a bigger hospital or larger hospital that can serve that patient. And also, rural hospitals tend to care for more Medicare and Medicaid patients in general. Now, out of those rural hospitals, 72% of those hospitals are considered a critical access hospital. And we'll go into what that means, okay? Hospitals can be independent, a system, or a network. Independent means that they're standalone, and it is becoming increasingly rare to see these independent hospitals. A network, it operates to connect with one another to deliver a range of services to a single community or multiple communities. Think of a system or a network hospital as sharing the healthcare costs and services provided. And a system, hospital system, is a lot like a network. Larger systems can offer specialty services as well as general services. But think of, they all have a standard of care in this system, okay? And you can see the percentages, how that breaks down. There's teaching versus non-teaching hospitals. So typically affiliated with universities, colleges, medical schools, and nursing schools, teaching hospitals provide medical and healthcare services while teaching and training healers of the future. The students, interns, and fellows are working and learning in these hospitals, and they are supervised by qualified physicians, teachers, department chairs, and other medical staff. And then non-teaching hospitals are affiliated with with medical schools and do not provide educational opportunities for students studying to become doctors, nurses, or other medical professionals. They provide necessary medical services to the community that they serve. The last one, federal versus local and state. When you think of federal, think of the VA. Very specific, federally funded. And state and local, many state hospitals are teaching hospitals that offer vital education experiences to students while meeting the medical care and treatment needs in their communities. And state hospitals often receive a substantial portion of their funding from the state, though they may receive grants or endowments from charitable organizations from the communities that they serve. Okay. So we mentioned a critical access hospital. We're going to dive into that and figure out what that means. So what is a critical access hospital? Almost 1/5 of the U.S. population lives in a rural area. Okay? And in 1997, Congress decided to designate a role called critical access hospital designation when in the 1980s and 1990s, a whole bunch of rural hospitals started closing down. Critical Access Hospital is a designation given to eligible rural hospitals by the Centers of Medicare and Medicaid Services, or CMS. A CAH designation is designed to reduce the financial vulnerability of rural hospitals and improve access to health care by keeping essential services in the rural communities that they serve. And as of 2019, there were 1,350 CAHs located in the United States. And as you can tell, with this picture here that we're in the state of Nebraska, and there's a whole bunch of little hospitals. Okay? Moving on. Hospitals must meet the following criteria to be designated as a CAW. They must participate in the state Medicare Rural Hospital Flexibility Program, and this is a funding opportunity to help with payment and reimbursement and financial services. Okay? A critical access hospital must have 25 or fewer acute care inpatient beds or swing bed services. We'll define later what inpatient versus swing bed is. Okay? But they must, the whole point is that there must be 25 or fewer beds. Must be located more than 35 miles away from another hospital. Some exceptions do apply, one of them being if a provider is deemed necessary to that area. Maintain an average length of stay of 96 hours or less, so that's 4 days, for acute care patients, and the hospital must provide 24-hour emergency care services 7 days a week. Okay, so we're going to look at those requirements with my hospital that I work for at CHI Health St. Mary's. Okay, we're located in Nebraska City. St. Mary's is an 18-bed facility that serves the community of Nebraska City, but also southwest Iowa and northwestern Missouri. We are affiliated with Catholic Health Initiatives, or CHI. Think of that as a system hospital. National health system committed to promoting healthy communities through innovative programs, collaborations, and partnerships. And also, just so I can point out that Nebraska City is about an hour away from Omaha, Council Bluffs, and about an hour away from Lincoln. If it works. What's going on? Oh. Catholic Health Initiatives. So we're part of this system called Catholic Health Initiatives. They're based in Englewood, Colorado. They operate in 19 states across the United States. They comprise of 105 hospitals. My division is called the Midwest Division. We have 14 hospitals, and 4 of those are critical access hospitals located in Nebraska or Iowa. And in 2019, we merged with another system of hospitals called Dignity Health to form Common Spirit Health, or CSH. It is the largest Catholic health system in the United States and one of the largest non-for-profit hospital systems by revenue in the United States. So, let's go. So Common Spirit Health. So I have St. Mary's Hospital, which is part of CHI Hospital, which merged with another hospital, and now this is us as a huge system called Common Spirit Health. We do have a mission, and we do have a vision, and we have values that we all, as a system, abide by and follow, okay? And I won't have to read that for you. So let's look at what my hospital, as a critical access hospital, what services do we have at our hospital? Remember, it's an 18-bed hospital, but we have acute care and swing bed patients. What that means is acute care is when you're very sick. We can care for you, but then if you can't go home quite yet, you can be put into a swing bed status, meaning that you can stay at our facility for a longer period of time to get healthy, so you can either go home, go to a nursing home, or another facility. We have labor and delivery, so we deliver a lot of babies at our hospital. Outpatient services, we have a basic level trauma center. Our goal is to stabilize our patients and to ship them to the bigger hospitals. We have an OR procedural center, so we do local surgeries. We have a huge diagnostic center, what involves radiology, we have MRI, different scans. We have a physical therapy and occupational therapy service. And we also have the Nebraska City Medical Center, which has providers, mid-levels, and specialty doctors that come to our hospital. And then we also do specialty services for our small hospital, including infusion. There's an infusion center, which we infuse chemotherapy medications at our hospital. We have a specialty clinic, so once a month, a specialty doctor will come and see those patients that would otherwise have to go to Lincoln or Nebraska or another hospital to get those services. And then we also have virtual health services, especially with COVID. We've had great success with that. We do a lot of our clinics have a telehealth or telemedicine aspect to them. Here's some statistics at St. Mary's. Now this is pre-COVID, okay, so fiscal year 2020, our emergency department saw 3,900 patients. Our acute care admissions were 128 admissions. Swing bed admissions, so those are the patients that can't quite go home but are able to stay and show improvement, 45 of them. We had almost 100 babies at our little hospital, about 300 surgeries, and our outpatient infusions were 2,700. Now so before we go on, let's just summarize what St. Mary's Hospital is. So with that, think about that pizza again. So as of right now, we're talking about my hospital is a critical access hospital, but it's in a rural area. Okay, so remember we talked about urban versus rural. We do have acute care, but we also have some swing bed services, but we're not considered long-term. We are a community hospital. We're not-for-profit. We're part of a system. We're a non-teaching hospital. We are state and locally owned. And so you can kind of get an idea of how our hospital is if you were looking at another hospital, like a bigger hospital in Omaha. Now we're going to transition to the pharmacy department. So I have a mighty staff of 4 people. So 2 full-time pharmacists and 2 full-time pharmacy technicians. Our hours of operation are Monday through Friday, 7:30 a.m. to 4:30 p.m. You might be thinking, okay, well, what do you do with the other 16 hours? Because, the hospital does not stop, Well, we have remote telepharmacy coverage, and they cover evenings, weekends, and holidays. What is the role of telepharmacy at a critical access hospital? Virtual healthcare, also known as telehealth or telemedicine, is a remote delivery of healthcare services or information using various technologies. And we, like I said, we have seen an explosion of that post-COVID. Telepharmacy provides rural hospitals with 24-hour access to services of a licensed clinical pharmacist, as well as real-time virtual medication order review and verification and clinical intervention services. The pharmacist uses two-way video or audio link to verify the right medication at the right dose is being delivered to the right hospital at the right time. Okay? Common Spirit Health Telepharmacy coordinates with activities across all of Common Spirit Health in 60 hospitals in 11 different states. They process roughly 50,000 orders per month for the state of Nebraska alone. And about 1,500 of those orders are for CHI Health St. Mary's a month. So, what are the benefits of having telehealth or telepharmacy? Access to services, which means that I get a break. I can go home. And I know that there is a pharmacist helping those nurses when they need it. The staffing and availability of a pharmacist is there 24/7, and the cost it helps bring down the cost of having a pharmacist staffed 24/7. And the nurses really do like that. They love the verification of orders in real time. They can talk to the telepharmacist if they need to mix a drug or identify a drug that they're not aware of. And any questions, they can call them as well. Okay. Our team, however, if I can get this to work, covers all the needs of our entire hospital. So we're going to dive into what services our pharmacy technicians help with. Mainly, we're going to talk about the inpatient department and then the pharmacy department. When I talk about the inpatient department, the essential service that they provide is drug delivery. Think about getting that medication to the nurse or to the patient, making sure things are stocked on the floor. But really, the technician are the eyes and ears of our hospital. They're the first ones to know that there's an issue. They let me know what needs to be done. They have daily interaction with our patients, our nursing staff, and our providers. They do daily refilling of our automatic dispensing cabinets. An automatic dispensing cabinet, if you do not know what that is like a placeholder, a place to put your medication so the nurse can grab the medication for a patient. That has to be refilled every day. That's drug delivery. And they also do daily checking and restocking of medications outside of the ADC or in supply carts or in the ORs, places that they do not stock in a dispensing cabinet. They will also check IVs, make sure that those IVs are running correctly, and when do we need to make another one. Okay. One of the unique services that we provide at our hospital in our inpatient department, we have our technicians obtain a patient medication history, or another name for that we call is MedRec. So our technician will go into the patient's room and try to get a complete and accurate medication history to help our nurses and our providers provide those medications while they're here. So sources of information that our technicians have to go through would be interviewing the patient or family members. Another one would be calling the patient's retail pharmacy or their previous stay. And then they also utilize third-party applications for refill information. You might have heard of Doctor First or Care Everywhere. That's an application that can tell us when the last time the patient refilled a medication at what hospital. So it gives us a more accurate idea if they're taking their meds. Again, accurate and complete medication list is what our technicians are trained to do. They will look at the prescription drugs that they're on, over-the-counter medications as well, and other items such as alcohol, tobacco, and other illicit drugs or recreational drugs. When we talk about this with our technicians, we talk about the 5 rights of drug administration. How many people know about the 5 rights of drug administration? And it was, at least when I was in school, it was drilled into my head. So we're going to talk about that here because it can apply not just to drug, or administering a drug to a patient, but also when you're getting that information for those drug histories. So the 5 rights. Making sure it's the right drug. Always knowing that it's what the generic name and the brand name are. The right dose. Making sure that we know what unit of measure we're talking about. Are we talking about milligrams? Are we talking about grams? Are we talking about units? The right route. Very important. There are a lot of drugs that have different ways of administering it, different forms. So IV, PO, sub-Q. The right time or frequency is very important. Is it given once a day? Is it in the morning or night? Is it twice a day? Is it 3 times a day? Is it as needed? And the right patient. It's very important to know that the patient is correct. And we use 2 forms of ID, usually their name and their date of birth. Again, it can be used to apply and applied when gathering accurate information. Okay. Now we're going to transition into the pharmacy department. When I think of the essential services that our technicians help with, it's drug maintenance. That's what I think of. So out of the pharmacy, drug delivery, in the pharmacy, drug maintenance. And what does that entail? Well, I have a technician who is also called our pharmacy buyer. So what does she do? She is in charge of daily ordering and purchasing of all of our medications in the hospital. She maintains the hospital inventory. She also orders specialty medications so that we have them for our patients for the next day, or if it's a new infusion, we'll have to procure that medication. And some of those medications have to go through the 340B drug pricing program, which we'll talk about in the next slide. They talk about, or they report drug shortages. They let me know if there's a drug shortage and what to do about it. What are we going to do to replace that drug that is on back order. And they comply with all drug recalls. So if there's a drug that needs to be recalled, again, what are we going to do about that? How are we going to get that medication to that patient? Is there an alternative drug that we can use? In the pharmacy and out of the pharmacy, out in the special areas, we are always continually checking for expired and outdated medications. I'm sure that's with everyone, but for us, it's continuous, never ends. So we look at our department, but we also look hospital-wide. Again, at those dispensing cabinets, in the crash carts, all over. So I mentioned the 340B drug pricing program. So what is that? It is a federal drug price control program. It is for qualifying providers serving uninsured and low-income patients in rural communities. And those could be hospitals, specialty clinics, or community pharmacists, or pharmacies. We can purchase outpatient drugs from the manufacturer at a discounted price. Compared to another hospital in, let's say, Omaha, my hospital can get it for a cheaper price. And with that medication at a cheaper price, the savings that we accumulate is supposed to go to indigent care and to help the community. Now, those medications could be for chemotherapy drugs, which at our hospital, we do have a fair amount of chemotherapy patients who need those drugs. Immunotherapy medications for, like, let's say, rheumatoid arthritis or asthma. There are some medications that are very expensive for asthma. And some oral medications can also be eligible for this discount price. My technician needs to know, does this patient qualify so that we can get that cheaper drug for them? So there are over 40,000 participating sites for the 340B drug pricing program. And we are subjected to federal audits for program compliance. In fact, last year I was part of that. So that was really fun. Oh man, it was a doozy. And that is run by the Health Resources and Service Administration. It's called a HRSA audit. Okay. Other things that we do in our pharmacy, the technicians have to know how to compound medication. So in this picture you can see that she's using aseptic technique, okay? Making sterile IV compounding in our IV hoods. So again, they need to know aseptic technique. And if you don't know what that means, what that is how to properly gown or donning and how to properly take off personal protective equipment without contaminating what you're making in the hood. We call it in the hood. So they know how to prepare and mix medications. A lot of times it is the technician that does that. In an emergency, I might go in there and make that medication, but I rely on my technician. They know how to mix and they know how to prepare the medication accurately. And medications that they might make in the IV hood are antibiotics, pre-surgery medications like for a pain block, for a knee or a shoulder, and especially chemotherapy specialty infusion medications. Those medications are considered hazardous material. So you have to double gown before you go into that special area to make those chemotherapy medications. And there's a whole requirement on how you do that. So my technicians have to do annual competencies to make sure they do that. And the other thing with all of this is they must clean the IV rooms. And there's daily, weekly, and monthly cleaning requirements. You're cleaning the ceilings, the walls, and the floors. It's a lot of work. And on top of that, room temperature control and pressure checks, making sure that the pressure in the rooms are compliant so that we're not growing bacteria in those rooms. So that was sterile compounding. Now, non-sterile compounding. My technicians know how to repackage drugs, called unit dosing, and a lot of people know how to do that. But we do a lot of it. So there's a picture of us unit dosing some of our medications there. We repackage tablets, oral syringes, and creams. And the most important thing with these as well is following all labeling requirements for the products. So making sure there's a lot number and an expiration date. And also, one thing I forgot to say was that barcode. That barcode has to scan at bedside, or we get a call from the nurses being like, "This isn't working. What's going on?" So they're really good at making sure that all of these things are compliant before we take them out to the nurses. All right. So my last two slides are working for a critical access hospital. What are the limitations and what are the advantages? Limitations first. Staffing shortages. That can be a problem. Again, I have 4 people who work in my department, and when one of them is ill or gone, we have to pick up the slack. So on-call availability and after-hour coverage is important. My telepharmacist can't do everything. So I might get a call, and like today, they called me and said, "I need you to help a nurse figure this out. Where is this medication?" Or sometimes they'll have to come in, my technicians will have to come in and make a medication that the nurse, it's too difficult for a nurse to make on their own. And then the traveling requirements. Thankfully, my technicians live about 10 miles away from the hospital, but in other places, you might have to commute in. Drug shortages, always a problem. I have a small inventory. So what do I do about that, right? I have a limited hospital formulary, and procuring those drugs can be an issue. So what do? I call other hospitals and other community pharmacies. Because I'm part of CHI Health, I could call a sister hospital to help me out and deliver those drugs to me. And I have a really good rapport with our community hospitals in Nebraska City too. So we work very well to get those medications to those patients. The other thing that's a limitation is the care that we can provide at our hospital. Higher level of care requirements, we just can't do that here. Our motto is we stabilize that patient in the ER and we ship them out if it's too advanced. So that would be our severely ill patients. I don't have an ICU where I am at. And anything that's high risk surgeries or procedures. So any mom that's going to deliver twins or a high risk pregnancy, they will not come to my hospital. Or try not to have them come to my hospital. Okay. All right. Now the advantages. We provide vital services to the underserved and isolated communities. And that, to me, is the most important. Because if it wasn't for our little hospital, those patients would have to travel an hour, hour and a half to the services that they need. There's opportunities for developing a broad range of skills working in a critical access hospital, meaning that my technicians, they know it all. They have to. Where in a bigger hospital, you may only work in one area. We need to know a little bit about everything to take care of our patients, because you never know what you're going to have that day. Diverse responsibilities compared to a larger institution. That is kind of the same a little bit, where we split those responsibilities between the four of us, and we still have the same amount of work that a bigger hospital has to do. We do it as well. It's just that those responsibilities are shared among us. We collaborate with urban care systems for better transition of care for patients. The greatest thing that I have to say is that I can call my sister hospital and ask them for information, and they're willing to help. And if there's a problem, my technicians are on that phone asking other hospitals, what do you do? How do we fix this? Flexible and efficient workflows under the pharmacist supervision. So again, we have a whole bunch of responsibilities, daily responsibilities, and my technicians are great problem solvers. We have to be efficient and to get all of our responsibilities done in a little limited time that we have to be there, 8 hours, and they do a great job. And we work with an interdisciplinary team, with the pharmacy staff, with the nursing staff, and other healthcare providers to provide the care that they need. Okay. So we'll go back over some of those questions. What are the following are the advantages of working in a critical care access hospital? Broad range of skills. Okay. You learn a lot. What qualifications are required to be considered a critical access hospital? All of the above. Okay? Lots of requirements, but. And then, which of the following is not one of the 5 rights of drug administration? The right doctor. It's not part of the 5. If you extend it to like 7 or 8, maybe it's in there. But the 5, it's very important. We do have the right doctor though, but it's not part of it. And what statement is true about the 340B drug pricing program? The program that allows a qualifying entity to purchase outpatient drugs from manufacturers at a discounted price. Okay. All right. I am done. If you have any questions. No? Yes?
Yeah. How do you handle outdated drugs with the pharmacy tax?
Outdated drugs?
Schedule that, yeah.
Well, the good thing is our dispensing cabinets have a daily report. So we know which drugs are going, we do a monthly report, so we know which drugs are going to be outdating. So we pull them prior to them being expired. We also, and anything that's not in our dispensing cabinet, we have this huge book. It's our floor stock book. So it's basically where the nurses have squirreled away all the little things here and there. We have to check those. So every month we're continually checking those medications in the dispensing cabinet, in the pharmacy, and out and on the floor to make sure that those medications are within date. If it gets really close to that date, we can talk to another hospital and say, hey, you have a patient who's on A, B, and C. Would you like to trade? Do you want to, so that we're not losing medication all the time. So.
I have questions.
Yes.
Before you commented something about after hours, if a nurse it's too big of a dosage thing or whatever situation, your techs will go in and do it?
Yes.
After hours?
Yes. Like today, we had a patient who needs an antibiotic. The nurses, it is required. The nurses need to come in and make a medication, but sometimes they can be too involved or to make it. So it's best if we can get a technician to go in there and make it for them. It relieves the nurse from actually having to draw out the dose, make sure it's correct, the concentration is correct. When my technician can do it for you, and then here you go, nurse, here's the med. One of them being, you've heard of a banana bag? Heard of that? So that's considered high-risk medication. So I don't want my nurses to make that. So I'll have a technician come in and make something like that, like a banana bag. Or we won't do it at all. It's very...
Who checks their work then?
Pharmacist. You can go on Telepharmacy. The telepharmacist, you have a camera. You can look at it. They can see it in real time. You show them the medications that you did. You pull up what you show, and you show them what you did on the computer. And there is real time. So we can say, yes, that's correct. No, that's not. Go back and fix this. So that's after hours. Mm-hmm.
Is that a special permission that you had to get? Because I thought the state of Nebraska didn't allow for telepharmacy in that aspect.
We do. We are allowed to have that in our facility. The telepharmacy service that we use also does it in other states, but specifically there are several hospitals in the state of Nebraska that we do real-time services like that. So.
And having your technicians, I know there's a pharmacist watching on video, but having a technician in the pharmacy, they have access into that pharmacy without a pharmacist.
Yes. Yeah, they're able to go into the pharmacy. There is a pharmacist through the video chat, so that you can see what they're doing. As long as, okay, the thing is if they can't do anything that is, there still needs that to be, the final check has to be the pharmacist. So if they have the ingredients and they have everything set out, and they know how to mix it, they can't give it to the nurse. Then it would have to be the pharmacist that checks it, that final check, or we'll have the nurse come in and make their own med if they really have to. So no, we have the technician do to their capability, to the most of their capability at our hospital.
And when your technicians come in and do that, are they doing that? Are they punching in and doing that? Are they doing that in their free time?
Oh, no, that's considered overtime. Yes, they would have to be clocking in, so we know what they're doing. Yes?
Does that fall under, I've heard of technicians that are scheduled PRN? Is that referring to? Like when they're called in, is that what that is or no?
No, PRN would be like, that wouldn't consider that a PRN. This would be like over and beyond for us. A PRN would be like they come in periodically if I need your help. So let's say the hospital has a whole bunch of patients, and I really need a technician to come in for a little bit just so I can get over this hump or over all the requirements. Then I might call someone who they meet the requirements, they've done all the training, but that PRN technician might work for my hospital, might work for another hospital. You can call them and say, hey, could you come in and help us for 4 or 5 hours? But there's PRN, there's part-time pharmacists, and there's full-time, technicians. Part-time technicians, full-time technicians, and PRN. I would say that's more of a designation of time. So, any other questions? Yes.
Yes. With your banana bag, wouldn't the pharmacy have the standard medication on hand to make this banana bag so you wouldn't have to bring in someone just to make a banana bag? Because, what is your standard medication for a banana bag? Isn't it multiple vitamins, thiamine?
Usually there's 3 things.
Yes.
Yes, and it depends on which hospital that you're working in. Sometimes they'll have the nurse come in and gown up and go into the IV room and mix it there. Sometimes because they need it right away, they'll make it at bedside, which we don't want them to do because that's 3 pokes. That's a lot of stuff to put into a bag that we think that needs more oversight. And we just, in some places, are banning banana bags altogether. So instead of giving them a banana bag, you give them oral medicine, or you might give them an IM or IV shot instead, so that we don't use banana bags at all. Yes?
Question, just piggybacking on the question that the young lady was asking, one of the technicians at the end there, I don't know her name, sorry about that. Coming in to mix difficult antibiotic medication for the nurse. That order, who puts the order in? How do you know that?
Yes. So we have an electronic system.
I know they already, you've given them the instructions over the teleprompter, whatever, telepharmacy, I must say. But how do you know what the order, is the doctor putting that order in for you to verify that order?
Yes. So how ideally, the provider puts in the order, the pharmacist verifies the order, out comes a label with the directions of use.
Okay.
Okay? So then the technician would take that label, follow the directions of use, have it all prepared, call the telepharmacist, have them look at it in real time to make sure that this is correct, the right dose, the right patient, everything